We are discussing Chapter 40, which is the hematological problems, including anemia, lymphoma, leukemia, and several other types of anemia, as well as blood transfusions. So anemia is a reduction in the number of red blood cells, amount of hemoglobin, or hematocrit. It is not a specific disease process itself. It is a symptom of other abnormal conditions within inside of the body. Things that can cause anemia or poor function of the red blood cells, like sickle cell anemia, poor diet, GI bleeding, bone marrow disease, genetic disorders. GI bleeding is the most common reason for anemia in adults. But the nursing care is similar for all the types of anemia. So anemia is resulting from the destruction of red blood cells. Sickle cell disease is the main one we're going to spend a little bit of time on. The sickle cell anemia is a genetic disorder. You see it primarily in the African American population. It does result in chronic anemia, pain, disability, organ damage, increased risk for infection, early death for these specific people. There's a lot of variety in how severe the disease is from person to person and when the organ damage complications might start. What you see in sickle cell anemia is the red blood cells are actually form a sickle, which means they're not their normal round self. They are significantly smaller, so therefore they are able to carry less oxygen to the main organs of the body. And because of this, you have a lot more blood vessel obstruction. You have ischemia in all of the tissues. The tissues are dying. And then things that can cause that specific type of sickling are hypoxia, dehydration, infection, pregnancy, alcohol consumption, and a change in the altitudes or a change in a person's body temperature. Also, stress and exercise can cause a sickle cell crisis. When the patient is in a remission, these sickle cells can go back to normal shape, but when they are in the crisis, then that is when they become that sickle shape and they're less able to provide the appropriate oxygen to the body cells. The average lifespan of a red blood cell is 120 days. In a patient who has sickle cell anemia, it is about 10 to 20 days, so it is much less than a normal red blood cell, and it causes just a lot of significant problems in these specific patients. Sickle cell crises have a sudden onset. Many can occur as often as weekly. Some of them can be once a year. Most of these patients are in good health the rest of the time, and again, these crises may occur to one condition at that particular time, whether it's like I said, a change in altitude or stress can bring these on. Sickle cell disease, if I didn't say it before, is a genetic disorder. These particular patients, these signs and symptoms, when they are triggered, the conditions can be mild, they can be significant. This is a long-standing disease process for the individual, and it can cause, like I said, can cause a lot of issues. Pain is the most common sign of sickle cell disease. You may, though, as the time goes on, can see cardiovascular changes. They have a high risk for heart failure because of the anemia. You want to be assessing your patient for shortness of breath, general fatigue, or weakness. They may present with murmurs, and they may also have priapism. Priapism is a prolonged penile erection that can occur with men who have sickle cell disease. It is because of the excessive vascular engorgement in the erectile tissue. It's very painful. It can last for hours, and most patients cannot urinate. Skin changes include pallor or paleness, cyanosis because they're not getting enough gas exchanged because of the decreased perfusion and anemia. Want to look at the lips, tongue, nail beds, palms and soles of the feet, and also your nail beds can have a bluish tinge due to the decrease in the oxygen levels. Another manifestation is jaundice. It results from the destruction of the red blood cells and the release of bilirubin. This buildup inside the body makes the patient appear yellow, especially in the sclera of the eyes. Because these patients are darker skinned, that is where you would want to look for the jaundice. You can also look in the roof of their mouth for a yellow appearance. A lot of these patients will also have ulcers on their lower legs because of the poor perfusion, especially on the outer and inner aspect of the ankle or the shin. These lesions can often become infected and requiring antibiotic therapy. Need to inspect the legs and feet. Very good for necrotic tissue. They can also have abdominal changes, especially damage to the spleen and liver. Kidney and urinary changes, of course, because of the poor perfusion and decreased gas exchange. Chronic kidney disease results as a result of the damage to the kidney nephrons. Early damage makes the kidneys less effective at filtering and reabsorption, so the urine contains protein, and the patient may or may not concentrate that urine. The kidneys will eventually fail, resulting in very little urine output. They can have musculoskeletal changes because of blood vessel occlusion. You will see patients who have increased risk for thrombosis. Joints can be damaged. These patients will hurt and have a significant amount of pain, changes in the central nervous system. Patients may have a low-grade fever during crisis, and they can also have seizures or manifestations of a stroke. We want to be, as calm and compassionate as we can. These are people that will need chronic pain therapy. They'll also need IV hydration to help dilute those sickled cells, and they may need oxygen during this time. So it's basically supportive measures, and these are patients who are treated with IV pain medication. Drug therapy for patients with sickle cell crisis, like I said, is IV drug therapy for at least 48 hours. The two drugs of choice are mainly morphine and Dilaudid. You don't really want to use NSAIDs with these patients because it really does not help their pain. Hydroxyurea is a medication that is used to help reduce the number of sickling cells in the body, and it does also help with some of the pain episodes to a degree. Glucose 6 deficiency anemia. Again, there's a really nice table on $7.99 that goes through the common causes. With glucose 6, it's just a recessive deficiency of the enzyme G6PD. Immunohemolytic is basically where the body does not recognize its own blood cells, so therefore it's killing the patient's own blood cells. Iron deficiency anemia is a deficiency of the iron stores of the liver. The laboratory value used to check that is the ferritin level. You can have iron deficiency anemia and not your red blood cells or your hemoglobin or hematocrit levels may be perfectly normal, or you may have a combination of both of the levels being low. To treat iron deficiency anemia, you actually need to give an iron transfusion or put the patient on iron supplements. But if your iron stores are that low, most of the time an iron transfusion will help that. B12 deficiency Anemia is a deficiency of vitamin B12. You will see that with dietary deficiencies. Anybody who has had any type of stomach surgeries, like a gastrectomy, a gastric bypass, a surgery called a Roux-en-Y, will have deficiencies like B12, folic acid, and will need to take those specific supplements probably for their life. Aplastic anemia is a disease process that is occurred from the exposure to what we call myelotoxic agents, things like insecticides, chemotherapies, benzene, radiation, hepatitis B, things along those lines. Polycythemia vera is a disease process that progresses in severity over time. It's not a disease process that can be left untreated. These patients do not live long lives after this diagnosis. It is actually where a patient has an excess of red blood cells or iron. They have to get rid of those excess red blood cells. These patients need to have phlebotomies, which is where they go in and actually have a unit of blood or 500 mLs taken from the body. And then they'll also need to have what we call apheresis. That's where they remove that unit of blood and some of the patient's other components, and then they reinfuse plasma back into the patient to help fulfill the volume, so that they have plasma in there but not the actual red blood cells. We want to increase hydration and help prevent clot formation. Anybody who has an excess of red blood cells, please remember, is at an abnormal increased risk for blood clots. Um, Again, other things that we can do for polycythemia vera is to drink in excess of 3 liters a day, avoid constrictive clothing. These patients will more than likely be on anticoagulants to help keep the blood thinner. Wearing support hose to promote venous return, elevating their feet, stop activity at the first sign of chest pain, and so there's a nice little chart on page 805 that goes through those particular things. Hereditary hemochromatosis. It is a recessive disorder, and you have a lot of iron deposits in the blood system that can help damage the organs, and it leads to organ failure. The disease is more common in men and appears in men during their 40s. Women can have signs and symptoms later in life because of the loss of menopause. The most common signs and symptoms of hemochromatosis are abdominal pain, liver enlargement, hyperglycemia, and then darkening of the skin. Down the road, you'll see diabetes, cirrhosis of the liver, endocrine failure, heart disease, and death. It's usually diagnosed on the basis of signs and symptoms, and then again, having really high ferritin levels. These way to help get rid of the hereditary hemochromatosis is again doing a procedure called a phlebotomy, and that's again removing a unit of blood from the body. A lot of these patients will be seen twice weekly for a month or two, and then when the ferritin levels and the hematocrit levels are back down to a normal level, they'll level off to maybe once a month. So lab levels that we're looking at with hemochromatosis are generally a ferritin level, which are your iron stores in your liver, and or the hematocrit levels. Myelodysplastic syndrome is considered a precursor to leukemia. It's caused by a formation of abnormal cells in your bone marrow. Patients with MDS have a decrease in all forms of their blood cells, red blood cells, white blood cells, platelets. Anemia is the most common problem with MDS. although the neutropenia and thrombocytopenia are often present as well. MDS occurs with most patients in the ages of 60 or older. It does have cancer-like features, and again, like I said, is considered to be a precancerous state. About 30% of patients with MDS do eventually develop to acute leukemia. So physicians like to try to keep MDS in remission as long as they can. The exact cause is really not known, but risk factors can include aging, exposure to pesticides, tobacco smoke, exposure to radiation or chemotherapy drugs can also be a cause. And then diagnosis is made by looking at the chromosomes and genes, which is done through a bone marrow transplant. Excuse me, a bone marrow biopsy. Leukemia is cancer. It is an uncontrolled production of red blood cells, which are also called blast cells, in the bone marrow. Your normal white blood cell count is around 3 or 4,000 up to 10,000. With leukemia, you will see white blood cell counts in the thousands, like 200, 100, 200,000, sometimes higher. And this is an emergency for that particular patient. Your bone marrow becomes overcrowded with immature, non-functioning cells. Realize these are not normal white blood cells. They're small. They don't function the way that they should. So the job that the white blood cells and the other reds and whites normally do is greatly decreased. Leukemia can be acute with a sudden onset, or it can be chronic with a slow, insidious onset. Leukemias are classified by type. They're classified as lymphocytic or lymphoblastic, and I'm not going to go into a lot of that. Just realize that with leukemia accounts for 2% of all new cases of cancer and 4% of all deaths from cancer. Patients who have genetic problems are more at risk for leukemia, such as Down syndrome, Klinefelter syndrome, and Fanconi's anemia. Immune deficiencies can also promote the development of leukemia. There's a chart on page 807 that goes through AML, APL, and ALL, and you just may want to look over that. Leukemia is treated with high-dose chemotherapy and sometimes radiation to help get that white blood cell count down. Leukemia can be put into remission sometimes for years. It just really depends on whether it gets caught in time. These patients, again, are at a greater increase for risk for infection, because again they have white blood cells that are very immature and are not functioning properly. And even when the blood count is normal or at a higher level, they're still immature and they cannot provide that protection. They are also at risk for increased risk for colds, flus, bronchitis, and things along those lines. These patients will have weakness and fatigue. There's a chart on page 808 that goes through the signs and symptoms with acute leukemia. They can have ecchymosis, open infected lesions, anorexia, weight loss, hematuria, fatigue, and headache. Of course, they can also have cardiovascular changes, reduced related to the perfusion and the gas exchange, heart murmurs, respiratory changes. The majority of the changes that happen with any form of anemia or any form of disease process because of a change in red blood cells or white blood cells come from the majority of the time with the hypoxia, because those red blood cells do not have the ability to deliver oxygen to all parts of the body. Malignant lymphomas. Let me go back to the previous slide for just a moment. The type of therapy, the chemotherapy that is used with leukemia, is called induction therapy. It consists of multiple chemotherapies started at one time, and the goal of therapy for leukemia is to hit it hard and fast. You want to be able to achieve a rapid, complete remission of all signs and symptoms of this disease process. A combination of multiple chemotherapies is combined, and then they may have some chemotherapies when they get outside the hospital. I do not expect you to know the types or the names of the chemotherapy, but just know that they do a combination. These patients are in the hospital for a long period of time for induction therapy, and realize that while they're getting this chemotherapy, their blood counts will drop drastically, and they have to wait for their bone marrow to recover. This is called being neutropenic. Neutropenic is when your white blood cells drop down to generally below about 1,000. These patients are at increased risk for infection. They have to be protected basically from the outside world. They may have side effects such as hair loss, mouth sores, of course, nausea. So just know that this, like I said, is an emergency for a brand new leukemic who has an excessively high white blood cell count. So back to our malignant lymphomas. Hodgkin's lymphoma can affect, it is a cancer. First off, it can affect any age group. It does tend to peak between your teens and your adults, and then again when you're adults in between their 50s and 60s. It does affect younger men and women equally, but it is more prevalent in men in the older group. The exact cause is really uncertain at this point. There is some link to viral infections like Epstein-Barr or HIV, and then again exposure to chemicals. The cancer usually starts in a single lymph node, and it contains a specific cancer cell type called a Reed-Sternberg cell, and that is the marker for Hodgkin's lymphoma. When the physicians think that the patient has HL, then they will do a specific blood test, and that blood test will come back with the Reed-Sternberg cell. And it can spread from one group of lymph nodes to the next. The most common finding we see with Hodgkin's lymphoma is large, painless lymph node or multiple lymph nodes. The patients may also have what we call B symptoms. B symptoms are fevers greater than 101. They can have heavy night sweats, unplanned weight loss. The presence of the B symptoms does mean that these patients will have a poor prognosis. Most patients don't have any of the B symptoms at the time of diagnosis, and may just go to the physician because of the large lymph nodes. A diagnosis is based when the biopsy reveals the Reed-Sternberg cells, and then it can be classified into different subtypes, which I do not expect you to remember. Hodgkin's lymphoma is again treated by chemotherapy. Of course, we want to check all of our lab work, CBC, electrolyte, bone marrow aspiration, and then a CAT scan of the neck, chest, abdomen, and pelvis to see what's going on with all of the lymph nodes, and to see in how many parts of the body that we are looking at needing to try and treat. Hodgkin's lymphoma is also one of the most treatable cancers that is out there. Radiation may be used for stages 1 and 2. With 3 and 4, a lot of times chemotherapy and radiation are used together. Some nursing management for signs and symptoms of Hodgkin's lymphoma focus on basically the side effects. Pancytopenia, which is the reduction of your reds, whites, and platelets, a lot of the times all at one time. They're at increased risk for infection, anemia, and bleeding, severe nausea and vomiting, skin problems seen from radiation, and then constipation or diarrhea. So basically, we as nurses are just taking care of these signs and symptoms, and then possibly administering the chemotherapy. And we also have to think about sterility for the men and infertility for the women. Non-Hodgkin's lymphoma includes all of the other lymphoid cancers that do not have the Reed-Sternberg cell. There are over 60 subtypes, which we will not go into. The exact cause is not known, but medications that cause the immune system to be present, to be suppressed, like HIV disease, these patients are more at risk for non-Hodgkin's. And also patients who have a chronic H. pylori infection can have non-Hodgkin's lymphoma. Patients, again, still have swollen lymph nodes or tumors that spread to other organs. And these enlarged lymph nodes may be the only signs and symptoms of the lymphoma themselves. Again, these are painless swelling of these lymph nodes. Okay. A diagnosis of non-Hodgkin's lymphoma is made only after a biopsy by the swollen lymph node. Multiple myeloma, real quickly, is a white blood cell cancer. It involves the lymphocytes, which is called a plasma cell, and this plasma cell secretes all kinds of antibodies. You have an overgrowth of these plasma cells in the bone marrow, and then these bone marrow cells become cancerous. So you have more plasma cells than you do white blood cells. Multiple myeloma is also treated with chemotherapy. This particular disease is more common in people older than 65 years, and it's higher in American blacks than in whites. The cause is unknown, but again, exposure to radiation, chemicals, things along those lines, these people, we tend to see more risk of multiple myeloma. Some patients have no symptoms at the time of diagnosis. Some have a protein in their system called a monoclonal protein or a paraprotein, and this can be in the urine or blood, and this may be the only finding. The staging system for multiple myeloma divides patients into multiple stages. I'm not going to require you to know that. The first signs and symptoms that the patient may see is increased fatigue, easy bruising, and sometimes bone pain. As the disease progresses, we see more bone fractures, hypertension, infection, and hypercalcemia. Diagnosis is made by x-ray findings, and you'll see bone thinning with areas of bone loss. And there's also a Bence-Jones protein that is found in the blood level itself. A bone marrow biopsy is performed to diagnose the disease process. Again, it's treated with chemotherapy. It can also be treated sometimes with radiation and also sometimes with oral medications. This disease remains largely incurable. We see great results with patients who have stem cell transplants. Thrombocytopenia is a decrease in platelets. Now, we all know that our platelets clump and help clot. So if we don't have a large number of platelets, then we're at risk for bleeding to death. It can occur from a large number of disease processes, anything that deals with our bone marrow. Can cause issues. The two types of coagulation disorders are thrombocytopenia purpura and thrombotic thrombocytopenia purpura. I'm not going to try to say these words again. ITP, or thrombocytopenic purpura, is when the circulating platelets is greatly reduced, even though the platelets are performing normally and the platelet production is normal, but we still just have a lower amount in our body. Basically, these patients are making an antibody against their own platelets. So basically, their body is killing those platelets. The trigger for the production of the antibodies is unknown, but can be linked to viral infections. ITP is most common among women between the ages of 20 and 50 and anybody who has an autoimmune disorder. ITP is first seen in the skin and on the mucosa in the membranes. Patients will have large bruises or petechial rashes. Those are those purple rashes on the arms, legs, upper chest, and neck. If the patient has a significant blood loss, then anemia may also be present. Some of these people can have intracranial bleeding. They can have strokes. ITP is diagnosed by a low platelet count and an increased megakaryocyte count in the bone marrow. And these patients are again at increased risk for bleeding, and their hematocrit and hemoglobin levels may be low. Patients are at risk for poor clotting and increased bleeding. Drug therapy to manage ITP focus on drugs that suppress the immune system, like corticosteroids, Rituxan, which is a form of chemotherapy, and then IV immunoglobulin can help with this. These patients frequently need platelet transfusions, especially when their platelet counts are less than 10,000. And just, of course, maintaining a safe environment to help protect the patient from bleeding. And then we'll be wanting, educate the patient on not being around things that may cause injury, not handling scissors, not going out to garden with their garden shears. They must be very careful. And then surgical management, sometimes you may need to go in and remove the spleen if the patient is not responding to the drug therapy, because the spleen is a site of where those platelets are being destroyed. Clotting factor disorders. Hemophilia is hereditary. It's a bleeding disorder with two forms of different clotting factor deficiencies. It's the clinical or the signs and symptoms of hemophilia A and B are clinical. I'm not going to make you differentiate between the two. Just realize with hemophilia, the patient has abnormal bleeding response to any trauma because of a deficiency in their clotting factor. So hemophiliacs just are what we call free bleeders. So if they're in a wreck or any type of a trauma, then they don't really have enough platelets in their body to go plug that bleeding site. They'll just continue to basically bleed out. Heparin-induced thrombocytopenia, or HIT, is it's another clotting disorder. You get an unexpected drop in your platelet count after heparin treatment. You don't really see this a lot. I've seen a couple of occurrences in my nursing career. It happens because of the increasing use of heparin. It is an immune-mediated drug reaction, and it's caused by heparin-dependent platelet-activating IgG antibodies in the heparin that bind with your platelets. And it basically allows the platelets to release procoagulants, which neutralize the heparin and increases the thrombin generation from the prothrombin. hit can occur in patients receiving any type of heparin, although it's more common after unfractionated heparin. It's higher among patients with risk factors of heparin use more than 1 week, or patients who have post-surgical DVTs and being female. The diagnosis is based on the patient's exposure to heparin, which can be up to 100 days before the event. Thrombocytopenia after heparin exposure is the hallmark sign of HIT, and that's basically what you need to remember. Once it's diagnosed, the patient is started on anticoagulation therapy, and if you'll just remember those two things, you'll be okay. We're going to go over blood transfusions real quick. Pre-transfusion, you always want to verify the prescription with another RN. Look at your chart. Make sure you have an order to give a blood transfusion and how many units. You want to test the blood donor's blood for compatibility. You'll draw a type and cross match, send it to the lab, and the blood bank will they will do a type and cross, make sure they know the patient's blood type, whether they have any antibodies that may interfere with that blood transfusion, and get the unit of blood ready. You want to verify the patient's identity with another RN, examine the blood bag label, attached tag, and requisition slip. When you go to the blood bank to get this blood, you'll take a specific piece of paper that prints out that has the patient's blood type. It'll have the specific numbers labeled on the bag for that particular patient, and then you'll read off all the information to the lab tech. When you get back up to the room, you will do the same thing with another RN prior to giving this person blood. Always check your expiration date, inspect blood for discoloration, gas bubbles, cloudiness. During the transfusion, you want to provide education. You need to explain to the patient why they're getting the blood, what type of reaction that may go on. These patients can spike fevers very quickly, have shortness of breath, have chest pain, back pain. I've seen a few patients with abdominal pain. Those are all signs and symptoms of a blood reaction. We take the vital signs before we ever go down to the blood bank to get the blood. We assess them immediately before starting the infusion. We stay with the patient for the first 15 to 30 minutes. Their blood vital signs, depending upon your facility, are gotten at 15 minutes, 30 minutes, and then generally hourly. I've already mentioned the other the side effects there. You want to administer the blood product per hospital protocol, which is generally 3 to 4 hours. You have 4 hours to infuse an entire unit of blood, and then assess for hyperkalemia. Red blood cell transfusions are given to replace, of course, lost cells from trauma, surgery, GI bleeds, things along those lines. Platelet transfusions are given for low platelet counts, active bleeding. If a patient has an immune dysfunction, a lot of times they'll go ahead and give a unit of platelets prior to an invasive procedure. Plasma transfusions are given to replace the blood volume and the clotting factors from the two clotting disorders that we talked about, hemophilia and heparin-induced thrombocytopenia. And then white blood cell transfusions are given very rarely to neutropenic patients. Transfusion reactions, again, patients can be febrile, they can be hemolytic, they can be allergic. You can have bacterial reactions. If a patient has CHF, COPD, you always want to start the blood out very, very slowly. They can get a circulatory overload, and then you can have a transfusion-associated graft versus host disease, which is basically where the body just reacts to the blood. You always want to check for, again, electrolyte imbalances, specifically potassium. And some facilities will have you use normal saline along with the blood products. You don't run them at the same time, but they will leave the saline up there in case in case the patient does have a transfusion reaction. You can stop the blood and then start the saline to give the patient hydration. This is the end of the chapter, and thank you very much.